Welcome to the deep dive. Today we're venturing deep, really deep into human anatomy. We're uncovering a condition that's, well, a master of disguise in the medical world. It's sometimes even called anatomy's silent killer.
That's right. A pretty dramatic name, but honestly quite fitting.
We're focusing on the obturator hernia, or OH. It's a specific, quite rare type of abdominal wall defect, and our sources, like Bailey and Love surgery, confirm it's often missed, usually until it becomes a real emergency.
And that element of danger is really what makes this topic so critical. When people think hernia, they usually picture something obvious, maybe a bulge you can see or feel.
Sure, like an inguinal hernia.
Exactly. But the obturator hernia, it completely defies that expectation. Its location is hidden, tucked away deep in the pelvis. This means that, well, the chance for an early diagnosis is often tiny. It frequently leads to these really dangerous delays.
And that delay is the crux of the danger, isn't it? The research is pretty stark. It presents late. I mean, in more than half the reported cases, the patient comes in already strangulated.
Which means tissue, often part of the small intestine, is trapped. Its blood supply is cut off. It's actively dying.
That rate, that high strangulation rate, is precisely why spotting the subtle signs is just so vital.
Absolutely. So our goal today for this deep dive is really to give you those aha moments. We want you to properly understand this obturator hernia. We need to unpack the anatomy, how it hides itself so well.
And look at who's most at risk. The demographics are quite specific.
Yes, and explore the modern surgical thinking. How do you actually repair a defect that's, well, surrounded by bone and critical nerves and vessels? That's tricky.
Okay, let's dive into the anatomy first. Where does this problem actually begin? For it to be so hard to find, the escape route must be really well hidden.
Oh, it is. It's a masterclass in anatomical concealment, really. This hernia doesn't just push through muscle like others often do. No, it uses a pre-existing pathway, a natural tunnel, basically. It goes through the obturator canal.
The obturator canal. Okay, so that's part of the pelvic bone structure itself. Help us picture where exactly that is.
Okay, think about the obturator foramen. It's that large sort of oval hole you see on the side in front of the hip bone, down near the groin area.
Right, the big opening.
Yeah, but that large opening is mostly covered up by the obturator membrane and muscles, which offer protection. The obturator canal, though, is just a small fixed tunnel right at the top part of that foramen. It's quite tight, maybe only about 2 centimeters long. And it runs sort of diagonally downwards and forwards out of the pelvic cavity and into the upper medial thigh.
So while the main foramen is covered by flexible stuff, muscle, and membrane, this canal bit is rigid because of the bone around it.
Precisely. The canal is bordered above and behind by the superior pubic ramus, that's bone, and then below and in front by the obturator membrane and fascia. Because that top edge is solid bone, the tunnel just can't stretch or expand. And that rigidity is the key reason, mechanically speaking, why this hernia strangulates so often and so quickly. Any bowel that slips in gets clamped down hard.
That structure really sets the stage for problems. Okay, so once the hernia sac, maybe with some fat or intestine inside, squeezes through that tiny tunnel, why don't we see or feel a bulge?
This is the concealment part. As the sac exits the pelvis through the canal, it doesn't pop outwards towards the skin like, say, a femoral hernia might. Instead, it immediately dives deep underneath a big muscle that acts like a shield. That's the pectineus muscle.
The pectineus, right. That muscle covers that whole area, doesn't it? It forms a sort of roof over where the hernia would be.
Exactly. The pectineus is involved in flexing and adducting the hip. It's a substantial muscle, and it covers the hernia protrusion. For the swelling to be visible on the outside, it would have to somehow push through that thick muscle, plus all the fascia and fat layers on top.
Which it doesn't usually do.
No. Instead, the swelling tends to push inwards, sort of medial to the femoral vessels hidden away beneath the pectineus. It might track down along the inner thighs nerve and vessel bundle. So this deep hidden spot is why just feeling around, which works for most other hernias, usually fails here.
That anatomical setup is just brilliantly dangerous, really. It means the most basic physical sign is useless, which makes understanding who gets this even more critical for even suspecting it. Who is most likely to develop this hidden problem?
The demographics here are, well, really striking. The sources all point to a massive gender difference. It's 6 times more common in women than in men.
6 times? That's huge.
It is. And age is almost always a factor, too. Most patients are older, usually over 60.
Okay, 6 times more frequent in older women. That's a really strong clue. Why? What's the anatomical reason for that big gender gap?
It comes back to the pelvic structure itself. The female pelvis is built differently than the male pelvis. mainly for childbirth. Specifically, things like the pubic arch angle are wider in women. This slight structural difference seems to create a slightly larger or maybe less angled path through the obturator canal compared to men.
Making it a bit weaker structurally against pressure from inside the abdomen.
That seems to be the idea. The passage is just inherently a bit more vulnerable in the female pelvic architecture.
Okay, that explains the gender difference. But why the sharp increase with age? And why are thin women specifically mentioned as being at higher risk?
Right. Those are the other key factors. It's about biological changes and sort of mechanical wear. After age 60, there's often a natural decrease in muscle tone. And crucially, there's often a loss of the protective peritoneal fat pad.
Ah, the fat pad. So normally there's fat cushioning these spaces.
Yes, exactly. In a younger, healthier person, this fat pad acts like a natural buffer. It fills the potential spaces around pelvic openings, including the obturator canal.
So as that fat pad shrinks with age or weight loss, the canal entrance becomes relatively wider, more open, more inviting for abdominal contents to slip in.
Precisely. And then you add other factors like multiple pregnancies, which can stretch and weaken the pelvic floor tissues over time, or significant weight loss, especially if it's relatively rapid, which can shrink that fat pad quite quickly.
It's a combination of factors, then.
It is. You combine the female pelvic structure, the general loss of fat and muscle tone with aging or illness, and you create this sort of perfect storm, mechanically, for an obturator hernia to develop.
So the take-home message for anyone listening, clinician or student, is clear. If you have an elderly, thin female patient with vague abdominal symptoms, maybe pelvic pain, but no obvious lump, obturator hernia has to be high on your list of possibilities. The demographic profile itself is the first major red flag.
And that really shifts the focus, doesn't it? Away from just feeling for a lump and towards taking a careful history, understanding the patient's pain. Since the swelling is hidden by the pectineus muscle leading to these delays, what are the main clues that should set off alarm bells?
Well, we mentioned it's painful, and the source material talks about a specific posture patients sometimes adopt.
Yes, that's right. Patients often try to ease the pressure instinctively. They might keep the leg on the affected side slightly bent in a semiflexed position. Trying to straighten the leg or move it outwards, abduct it, or rotate it inwards often makes the pain much worse. It's a deep, sort of boring pain.
Because those movements stretch the muscles and fascia around the obturator canal.
Exactly. It aggravates the irritated structures.
Okay, that helps differentiate it from just general abdominal pain. But the real diagnostic signature, the thing that makes this hernia so insidious, is how it can totally mislead you. Let's talk about that referred knee pain. It seems to be the absolute key clue.
It is. This is probably the single most critical aha moment for understanding OH. And it's why so many patients initially go down completely the wrong diagnostic path. We know the hernia sac pushes on the obturator nerve as it squeezes through that tight canal. But in more than half of the cases where it's strangulated, the patient doesn't report pain just in the hip or groin. They feel it vividly referred down to the inner side of the knee.
Pain in the knee, caused by a hernia in the hip area. On the surface, that sounds almost impossible. How does that work anatomically? Why the confusion?
It traces back to where that nerve comes from and where it goes.
Yeah.
The obturator nerve starts in the lower back, from the lumbar plexus, specifically the L2, L3, L4 nerve roots. It travels down through the pelvis, goes to the obturator canal, and then it splits. Gives sensory nerves to the inner thigh and the hip joint, and motor nerves to the adductor muscles, the ones that pull your leg inwards.
Okay.
But crucially, one of its branches, sometimes called the geniculate branch, or a terminal cutaneous branch, travels all the way down to supply sensation to the skin and the capsule around the knee joint itself.
So when the nerve trunk gets squeezed back up in the obturator canal, the pain signal is so strong, the brain gets confused. It interprets the pain not just at the compression site, but also along the nerve's furthest sensory reach, which is the knee.
That's exactly it. This specific phenomena, especially when the pain gets worse with thigh movements like extension or adduction, is known as the Hauschip-Romberg sign. It's the clinical hallmark. The nerve compression creates this intense irritation that radiates distally, convincing everyone, patient and often the doctor, that the problem must be in the knee, an orthopedic issue.
Let's paint a picture. An elderly woman, fits the profile, thin, over 60. She comes in with sudden bad pain, but it's localized to her right knee. Maybe she's limping a bit. If the doctor doesn't know about the specific nerve referral pattern, what happens next usually?
Oh, it's often a diagnostic disaster, frankly. They'll likely order x-rays of the knee, looking for arthritis, maybe a torn meniscus. They
Whoopsie.
might suggest physical therapy, maybe prescribe some anti-inflammatories for the knee pain. Weeks could go by.
While the trapped bowel inside the hernia is dying.
Precisely. It's a classic case of, focusing too narrowly on the symptom, the knee pain, and missing the actual underlying emergency in the abdomen. That delay, the time wasted chasing an orthopedic red herring, is a major reason why the mortality for this hernia used to be so incredibly high.
So that knee pain is the definitive, non-palpable clue. Are there any physical exam maneuvers a clinician can try, even if the swelling is usually hidden?
Well, yes, but by the time you're doing these, you should already have a very high index of suspicion based on the history and demographics. The exam needs deep access. Sometimes, on a careful, deep vaginal or rectal examination, you might be able to feel a tender, perhaps subtle swelling high up in the pelvis. Near the pubic bone, in the region of the obturator foramen, you're essentially trying to feel the hernia sac from the inside before it fully exits the pelvis.
Okay. And what about that specific leg movement mentioned in the source, the one that might make a swelling appear?
All right, the sources mention that sometimes, and it really is just sometimes, a swelling might become slightly more apparent if you position the limb very specifically. You need to have the hip flexed, abducted, moved outwards, and rotated outwards. The idea is this might relax the pectineus and adductor muscles just enough.
To let the underlying hernia sac bulge a tiny bit more.
Potentially. But honestly, these signs are often very subtle or completely absent. It just reinforces why you really need imaging when the clinical picture fits, regardless of the physical exam findings. Given how incredibly tight and rigid that obturator canal neck is, it's really no surprise that the usual presentation is, well, the worst-case scenario. When patients finally do present, the hernia has often already strangulated.
And it's not just straightforward strangulation causing a full blockage. The sources highlight a particularly dangerous type, one that perfectly fits the sneaky nature of OH, the Richter's hernia.
Ah, yes, the Richter's hernia. That is perhaps the most insidious complication, and it's vital to grasp why it's so deadly. In typical strangulation, a whole loop of intestine gets trapped. The entire inside the lumen is blocked off. That leads to pretty traumatic, immediate symptoms. Vomiting, can't pass gas or stool, belly gets very distended, the classic signs of bowel obstruction.
But a Richter's hernia somehow bypasses those obvious obstruction signs. How does that work?
In a Richter's hernia, only a part of the bowel wall gets trapped in the tight opening, usually just a small knuckle of tissue, typically from the side opposite the blood supply attachment, the antecenteric border. Because it's only part of the circumference, the main channel, the lumen of the bowel, can actually remain open.
Oh, wow. So food and gas can still pass through.
Yes, at least initially. This means the patient doesn't get those immediate, severe symptoms of a complete mechanical blockage.
So they have a piece of bowel that's trapped and dying, but they might still be passing gas, maybe even having small bowel movements. That must cause terrible diagnostic confusion.
It absolutely does. The patient might present with just vague abdominal discomfort, maybe that referred knee pain we talked about, perhaps feeling generally unwell, without the clear signs of obstruction. This can lead the physician to think it's not an urgent surgical problem. But meanwhile, that small trapped piece of bowel wall is rapidly losing blood supply, becoming ischemic, then necrotic, dying.
And that process, the necrosis of just a small patch, happens fast.
But very fast, often much faster than if a whole loop were strangulated. And the end result isn't blockage, it's perforation.
So the dying bowel wall breaks down and leaks.
Exactly, it perforates, spilling toxic gut contents into the surrounding tissues deep in the pelvis, often in the extraperitoneal space. This leads quickly to severe infection, sepsis, peritonitis, and potentially multi-organ failure. The lack of the usual obstruction symptoms masks this deadly process, often delaying diagnosis and surgery until it's almost too late. That mechanism is why Richter's hernias, historically, had such appallingly high mortality rates.
Okay, so clinical exam is unreliable, symptoms can be vague or misleading like the knee pain, or dangerously subtle like with the Richters. How do we reliably get to the diagnosis in the modern hospital setting?
We have to rely heavily on imaging. We move past the limitations of the physical exam. Obturator hernias are most often diagnosed using a CT scan. When a patient, especially one fitting the demographic profile, presents with that unexplained pelvic or deep groin pain, or maybe some subtle signs hinting at a partial bowel obstruction, a CT scan of the abdomen and pelvis is usually the next step.
And what does the CT actually show that confirms it?
The CT gives you a clear, definitive picture. You can literally see the loop of bowel or sometimes fatty tissue like omentum poking through that specific anatomical hole, the obturator canal. It also gives crucial information about the condition of that trapped bowel. Are there signs of fluid around it? Is the wall thickened? Does it not enhance with contrast? These signs point towards strangulation and help the surgeon's plan. It's really the moment the silent killer is finally unmasked on screen.
It's interesting, too, that sometimes these are found completely by chance, right?
Yes, that does happen occasionally. You might see an asymptomatic obturator hernia defect, incidentally, during a laparoscopy done for something else. You might spot a little dimple or outpouching of the peritoneum on the side wall of the pelvis, just under the pubic bone. But that's where. Usually the diagnosis comes only after symptoms have become severe enough to warrant an emergency investigation. Hashtag surgical management and advancements.
All right, given the very high chance of strangulation and the fact that it often presents as an emergency, surgery is clearly mandatory and usually needed quickly. Since the diagnosis might still be a bit uncertain until the CT results are back or even until the surgeon actually looks inside, how is the initial surgical approach typically decided?
Yeah, because of that uncertainty, especially about whether the bowel is still viable. Was it a Richter's? Is it already dead tissue? The primary approach is often still a laparotomy. That's a standard open operation, usually through an incision down the middle of the abdomen or sometimes a lower transverse one. It gives the surgeon the best access to see everything, check the bowel properly, and remove any damaged sections if needed.
Okay, so they open the abdomen. What's the first step to actually see and work on this hernia, which is tucked away so deep in the pelvis?
Getting a good view is absolutely crucial in that deep space. So the surgical team will immediately put the patient into the Trendelenburg position.
Head down, feet up.
Exactly, head down tilt. Gravity then helps pull the loops of small intestine out of the pelvic bowl, giving the surgeon a clearer line of sight down towards the obturator canal area.
Now, the trapped bowel or tissue is stuck because of that rigid opening, that neck. What exactly forms that tight ring, and what are the dangers when trying to free the contents?
The tight part is primarily the obturator fascia, especially where it's bound tightly against the pubic bone. The first goal is always gentle reduction, freeing the trapped tissue. If the bowel looks like it might still be alive, the surgeon needs to carefully widen that tight opening just enough to release it. This often involves very carefully inserting a finger or maybe some specialized blunt forceps to gently stretch the constricting fascia.
Okay, gentle stretching first. But what if that doesn't work? What if they absolutely have to cut the fascia to get the bowel out? That sounds incredibly risky down there.
It is hugely risky. This is where precise anatomical knowledge is just non-negotiable. If you have to incise the obturator fascia, you absolutely must know that the obturator artery, vein, and nerve are running right there, immediately next to, or sometimes even within the hernia sac's neck.
Wow, so you're operating in a deep, confined space next to bone with major blood vessels and a key nerve literally right beside the tissue you need to cut. How on earth do you avoid disaster?
The cut has to be made in a very specific direction. It must be parallel to the line of the obturator vessels and nerve. If the incision goes the wrong way, or if it's too deep or aggressive, the consequences can be devastating. You could cause massive bleeding that's extremely hard to control deep in the pelvis.
Or permanent nerve damage.
Or permanent damage to the obturator nerve, leading to paralysis of the thigh's adductor muscles and potentially severe chronic nerve pain, neuralgia.
Yeah.
Surgical precision and discipline are absolutely paramount here.
Okay, so let's say the incarcerated tissue is freed. Its viability is checked. Maybe it's okay and goes back in. Maybe a piece of bowel needs to be removed.
Yeah.
Now comes the repair. You mentioned earlier you can't just stitch the hole closed like with some other hernias. Why does a simple suture repair fail here?
That's one of the fundamental challenges with OH repair. The hole has really unforgiving edges. For one thing, one edge of the defect is bone, the superior pubic ramus. You simply cannot sew into bone effectively. And second, the obturator nerve and vessels run right through the very spot where you'd want to pull tissues together with stitches. If you tried to pull muscle or fascia across that bony gap under tension,
you'd risk strangling or compressing the nerve and vessels.
Exactly. You'd almost guarantee nerve damage or vascular compromise. So a tension-free repair is absolutely essential for a safe and lasting fix.
Which brings us to mesh. That's the standard way to achieve a tension-free repair, right?
Yeah.
What's the recommended technique here?
Yes, mesh is the standard. The clinical consensus is that the defect is best repaired using a flat piece of prosthetic mesh laid over the opening. typically placed in the extraperitoneal plane. This means placing the mesh behind the abdominal lining, the peritoneum, but in front of the muscles and fascia. It covers the whole like a patch, reinforcing the whole area without putting tension on the bone or risking entrapment of the nerve and vessels. The mesh acts as a buttress.
What about those tricky situations like if the patient had a perforated Richter's hernia? If the area is badly infected or contaminated with bowel contents? We know synthetic mesh in infection is usually a bad idea.
That's a really important exception. You're right, putting synthetic mesh into a heavily contaminated field massively increases the risk of chronic infection, abscesses, mesh erosion, ongoing problems. So in those rare but complex cases where mesh is just too risky, the surgeon has to fall back on using the patient's own tissues. The sources mention that sometimes the broad ligament that's a structure in the female pelvis, and remember, most patients are women, can be mobilized and stitched over the defect, or perhaps used as a sort of plug. It's about providing some kind of closure or reinforcement. Using available nearby tissue when putting in a foreign body like mesh is contraindicated.
Okay, that covers the open approach, often used in emergencies. Let's talk about newer, minimally invasive techniques, laparoscopy. We know open surgery is often needed for strangulation, but what about elective repairs or cases diagnosed early before strangulation?
The role of minimally invasive surgery, like laparoscopy, is definitely growing for obturator hernias, especially in non-emergency settings. The laparoscopic TAPP repair, that stands for transabdominal peritoneal, is considered highly effective. With TATP, the surgeon goes into the abdominal cavity with a camera and instruments, makes a cut in the peritoneum, the abdominal lining, over the hernia defect, and then creates a space behind that lining, the peritoneal space.
And what are the advantages of doing it this way laparoscopically, especially thinking about that dangerous nerve and vessel bundle?
The biggest advantage is probably visualization. Looking at the defect from the inside, magnified on a screen, allows the surgeon to see the obturator nerve and vessels very clearly as they enter the canal. This makes placing the mesh much more precise and potentially safer. And because the mesh is placed in that peritoneal space, it can be spread out nice and flat to cover the whole area well, with less risk of it folding or shifting.
How is the mesh usually secured in this very sensitive area, given the risk of chronic pain we discussed?
That's a critical point, especially for long-term patient outcome. In the past, surgeons might have used staples or tacks to fix the mesh in place. But using sharp, penetrating fixation like tacks right near the obturator nerve carries a significant risk of causing long-term chronic neuralgia, that debilitating nerve pain.
So what's the preferred method now?
So the modern preference, especially in that extraperitoneal plane near the nerve, is often to use tissue glue to fix the mesh gently. Or in many cases, surgeons might rely simply on the pressure from inside the abdomen to hold the large flat mesh in place without any fixation at all. This deliberate avoidance of penetrating fixation is specifically aimed at minimizing the risk of nerve injury and subsequent chronic pain.
That focus on preventing nerve injury sounds like a huge step forward for quality of life after surgery. But even with laparoscopy, there are still major limitations, especially when dealing with the acute strangulated emergency, right?
Absolutely. Yeah. And this is a crucial warning that comes through strongly in the surgical literature. While laparoscopy is great for planned elective repairs, it can be very difficult and frankly dangerous to try and reduce an incarcerated or strangulated obturator hernia laparoscopically. The reason comes back to that narrow, rigid, bony canal entrance. Through the laparoscope, the surgeon just doesn't have the same direct feel or leverage on the trapped bowel as they do in an open operation.
And if they try to pull too hard on bowel, that might already compromise, trying to yank it free from that tight, bony grip.
The risk of tearing the bowel wall, causing a perforation right there during the operation, is extremely high. Applying too much traction on potentially ischemic or necrotic bowel is just asking for trouble.
So what's the guidance?
If the reduction is proving difficult laparoscopically, or if there's any doubt at all about the bowel's viability once it's freed, the surgeon must be ready and willing to convert the procedure immediately to an open laparotomy. Switching to open surgery allows for safe, manual reduction, direct visual inspection of the bowel, and any necessary resection. Patient safety has to come first, always, over sticking rigidly to a minimally invasive approach in these high-risk emergencies. Making that switch is often the sign of experienced surgical judgment.
Wow. This deep dive has really highlighted the dangers hidden in anatomical details. We've seen how the obturator hernia uses its deep location, the bony canal, and even nerve pathways to hide, often mimicking something else entirely. So for everyone listening who needs to really lock in this essential, potentially life-saving information, let's summarize the three absolute key takeaways.
Okay, first, absolutely cement the demographics. This is overwhelmingly a condition affecting thin, older women, usually over 60. That's due to that mix of pelvic shape and the age-related loss of the protective fat pad. That profile alone should raise suspicion.
Got it. Second, the core challenge of diagnosis. Remember, you usually cannot feel a lump. The critical clinical clue is often that misleading knee pain, the referred pain down the obturator nerve's geniculate branch. Because the physical exam is so often negative, the reliable way to diagnose it is with a high-quality CT scan, typically ordered for unexplained pelvic pain or subtle obstruction signs.
And third, the complexities of treatment. Surgery isn't optional. It's mandatory because the risk of strangulation, especially Richter's type, is just too high. The repair itself is tricky because of the bone and the nearby nerve and vessels. So the standard is a tension-free repair using flat mesh placed in the extraperitoneal space. This is often done laparoscopically, TAPP approach, using fixation methods like tissue glue specifically chosen to avoid injuring the obturator nerve.
What really strikes me is how this rare condition demands such deep, three-dimensional thinking about anatomy, about obscure nerve branches. The margin for error seems incredibly small, and just knowing about that referred knee pain symptom could literally be the difference between timely surgery and septic shock for a patient.
What's really interesting is that the high danger here isn't usually due to a failure of surgical skill once it's identified. It's overwhelmingly due to a failure of clinical recognition beforehand. It highlights a broader point in medicine, I think. The biggest diagnostic traps often aren't the common things, but understanding those specific, subtle anatomical variations are exceptions that let rare conditions perfectly mimic something common and benign.
That point about anatomical sensitivity, especially around the nerve, leads perfectly into our final thought for you to consider. We talked a lot about the obturator nerve and vessels being right there and using techniques like tissue glue instead of tacks to avoid chronic nerve pain from mesh fixation. So considering this inherent risk of chronic neuralgia when putting any synthetic material so close to that sensitive nerve bundle, how might future surgical innovation tackle this? Could biologic meshes derived from animal or human tissue, or perhaps fully absorbable synthetic meshes, be developed or refined specifically for this location? Could they provide enough strength to prevent recurrence while truly minimizing that long-term risk of chronic nerve pain in this very tricky pelvic region?
That's certainly a key area of ongoing research and development. Finding that perfect balance between repair durability and minimizing long-term nerve complications in this specific, challenging anatomical spot is still a major goal.
Something for you, the listener, to mull over as hernia repair continues to evolve. Thank you for joining us for this deep dive into the obturator hernia. We'll catch you on the next one.